All right, good afternoon, everyone. We're gonna get started right now. Today, we're gonna have a very special um, academic forum. We're gonna have a multiple speaker with us. So, my name is Daniel. I like to welcome you to the UNSW Psychiatry Academic Forum. Before I introduce our speakers, I would like to acknowledge the Bedegal people that are the traditional custodian on the land on which UNSW Sydney sits. I will also like to pay my respect to the elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders who are present here today. Today we are honored to have Professor Julian Schroeder and his team speaking to us. Julian is a neuropsychiatrist that hosts the inaugural chair of intellectual disability mental health at the UNSW. He also heads the Department of Developmental Disability and Neuropsychiatry, 3DN, within the School of Psychiatry or Discipline of Psychiatry and Mental Health at the UNSW. Julian and his team work to improve health policy, practice, and support for people with intellectual or developmental disability. The team is involved in teaching, training, health promotion, and the development of educational resources. 3DN conducts research with high translational benefit to the disability and health sectors and provide consultancy of the highest standard, including clinical consultations, advocacy, and contribution to policy and legislative reviews. So we'd like during this talk, please post your question for the presenters in the Q&A section at the bottom of your screen, and I will ask a question on your behalf. So now, without further ado, it's my pleasure to introduce Julian and his team. Julian.
Thank you so much, Daniel. It's a real privilege for our team to be with you today, and we will be hopefully entertaining and exciting you with the prospects of using linked data in disability and mental health research. We are presenting on behalf of a wider team that engages in research in this area, including in data linkage. And you'll be aware that everything you hear really is contributed to by a much bigger team. It reflects a communal effort over many years now to build this data capacity that we are keen to share. The strategic purpose in doing so is really to introduce you to the nature of the data sets that we have that are available for collaboration with other researchers, and to excite with prospects of a new generation of data linkages that we and others are working on that really shed some light on the health and well-being of people that we care really passionately about. So this is the title of our talk today, and we will be going through one by one and coming back to me at the end. I just need to acknowledge Tim Watkins is unable to be with us due to unforeseen circumstances today that are well beyond his control, and he sends his apologies. And Prepon, our senior data analyst, is more than capable of presenting the content that he had previously conceptualised there. I'm going to briefly talk over our data sets and what they contain so that we can get a sense of where we're going. But before I do that, I'd like to give some acknowledgements, both of those with lived experience of disability and mental health, and I'd acknowledge those who support them as well at the beginning of this presentation. I'd also just like to acknowledge the rich sources of funding for our work, which is entirely externally funded, and the projects that you hear about wouldn't have been possible without this collaboration. Just in terms of what 3DN does, we have a research program which is strongly translational. I hope that comes across. It's inclusive in its nature. It thrives on cross-sector partnerships, and that's reflected in the nature of data sets we've been able to access. And we work with people with lived experience who inform our work and the directions that it takes and help us understand and interpret the results, including those from our data linkage work. Data linkage is essentially bringing information from different sources together. There's a unique identifier in that data for each person, and from that we're able to construct a sequence of events or see an event, for example, death of a person, or a series of events, for example, the service system contacts, which contain information about the person, their service contact diagnosis, and so on. We must remember that the data sets have been constructed for an administrative purpose, not a clinical one, and they involve accessing the data through data custodians and it being linked with data linkage units, providing that functioning. It allows a shift essentially from data centred around the agency and collecting it for their own needs to data centred around the person. And often when you're constructing a linkage across multiple data sets, you're moving from a single agency view to a multiple agency view. And this provides unique insights, particularly in the way the services systems work together or don't work together to improve the outcome for the person or population of interest. We've seen a rapid improvement in the data capacity in Australia from first generation through to second generation, and now conceptualising third generation data assets. The first generation are usually single domain and a single use asset, and an example is the work by the Population Health Research Network. The second generation are more enduring, multiple domain single jurisdiction or enduring single domain multi-jurisdiction linkages. And the third generation that I'll come to at the end of the talk involve enduring multiple domain, multiple jurisdiction data sets with pre-approved users in a streamlined process and with a portal that is accessible and produces insights that are promoted to the general public, to the user groups, for example, people with disability in the context of the National Disability Data Asset, and makes that data also available to users and agencies, so researchers and agencies who have a vested interest in improving policy and practice. So we're moving from something that is relatively less sophisticated through to something that is much more complex and also harder to administer. In our own work, we're interested in people with intellectual and developmental disabilities. And here the imperatives come from a number of key sources of recent times, particularly the Royal Commission's, Disability Royal Commission's finding of systemic neglect in healthcare for people with cognitive disability, and also from the new disability strategy, which has a whole outcome area 6, based around health and wellbeing. And there are key priority policy areas there for both health and disability services to work together. And there we find the linkage a very attractive prospect. One reason it is so critical is that if we just simply look at one services system, we don't get a full view at a population level of the needs of the group. An example here is you can see this is the dashboard from the NDIS quarterly report, and you can see that in New South Wales, we're able to identify just over 30,000 people with intellectual disability using NDIS. And if you were to use that data alone in understanding the needs of people with intellectual disability in New South Wales, you'd be sadly misguided. And I'll show you why. In our own linkages, bringing together multi-agency data, earlier we identified over 90,000 people living in New South Wales, and currently I think we have about 117,000 people living in New South Wales with an intellectual disability in our data sets. And so you can see the value in bringing together multiple different data sets. In each of the data sets we've brought together, there's no universal identifier. People are not adequately represented. In fact, we've shown very low rates of representation in health services contacts. Only 1 in 4 of each health contact accurately codes the presence of intellectual disability. And so we know that bringing together the multiple sources gives more accurate representation. And I think it's similar for other user groups. The enablers of the work revolve around funding, having the time and the tenacity to stick with a long process of application and approval and then access to the data after it's linked, having a team with capability to analyse the data, and having a clear understanding of how you might use that in a well-developed knowledge translation strategy. The strength of sector partnerships can't be underestimated. These are pivotal for taking action on the insights that the data develops. Our own journey has been incremental. Our modest start with the first linkage that we did was something that both Tony Florio and I led, and that was literally asking local health districts and disability services in New South Wales for access to their minimum data set in ambulatory mental health and the disability services minimum data, and linking those two as a proof of concept and showing the high mental health needs of people with intellectual disability as represented in ambulatory mental health data. And that was something that was linked ourselves and then stripped of identifiers. And of course, that wouldn't happen in this modern era. Our linkage 2 was linked for us by the Centre for Health Record Linkage and involved a much broader linkage across multiple different data sets here at the top, and then looking at outcomes at the bottom here. And here we were able to bring together cohorts of all people in New South Wales who could be identified with intellectual or developmental disabilities, all people with mental health, and all people with neurological disorders. And we're able to see them for the first time in this multi-agency linkage. We updated that in 2017. And then in 2021, we extended this by bringing some of the data sets in from the Commonwealth that were of interest. Here, of course, we're interested in prescribing information from the Pharmaceutical Benefits Scheme, out-of-hospital specialist and allied healthcare is represented in the MBS item numbers and also primary care data. And of course, things that were very useful in terms of preventative healthcare, things like immunisation data, national bowel screening data, and cancer data. And of course, we're also linking to things like death, information about death and cause of death. And so this much more expanded linkage is just based around a cohort of people with intellectual disability. It involves quite a degree of cooperation between both the Centre for Health Record Linkage and AIHW to execute this. And we were able to bring in a control cohort, which were comprised of people we knew didn't have intellectual disability living in New South Wales. And we were able to access about 450,000 controls that were sociodemographically matched to our population with intellectual disability. So we can make realistic comparisons about health outcomes and service system use and costs. I think Prevalence will talk further about the multiple barriers that exist in the process of linkage and its administration, so I won't dwell on that. But I'll talk more about its use in advocacy, policy, and some of the talks will illustrate its use in terms of evaluation of health services and so on. Just taking you through the Linkage 3, the study cohorts in Linkage 3, I highlighted that we're able to identify these population groups in that linkage. And we were able to look at their use of services, for example, disability services or health services. And so the linkage looked like this. It took into account services systems related to health, disability, corrections, and some other more bespoke, including the Department of Education disability data and the Public Guardian in New South Wales Ombudsman's data. And the corrections data is of particular interest, and we'll come back to that. The linkage record was certainly very substantial, records of over 2 million individuals with multiple records, 35 million records. And so we're able to see, for example, people with intellectual disability, that they're very high users of both emergency departments, of non-inpatient health services, non-mental health inpatient services, and mental health services in New South Wales. We looked at costs. So our data at that point, we had data for people with intellectual disability that represented 1% of the New South Wales population, And we saw that they represented 6% of New South Wales mental health population, but because they stayed twice as long, they were using or acquiring 12% of the state's mental health budget to meet their needs. This is very valuable data for planning a response to better health services. We saw that mental health admission metrics were really quite startling, that people with intellectual disability were 5 times likely to be ultra-long stayers and much more likely to be frequent flyers to the service, and they had certain characteristics. We could see that having an intellectual disability impacted the trajectory after first ever psychiatric admission, and that second only to drug and alcohol comorbidities, intellectual disability was the biggest driver of return to emergency departments and inpatient services at a short interval, 1 month, 2 to 5 months, and 6 to 24 months after index admission. We can see that emergency department services are used extensively by people with intellectual disability. The blue line here is showing the rate of emergency department use per 1,000 person years, and we can see that it's vastly different to the general population. We used it extensively in understanding the mortality and cause of death and potentially avoidable deaths for people with intellectual disability. And you can see that several papers there were used extensively in advocacy. And this is one of the key bits of work which was a catalyst for a new national roadmap that was developed in intellectual disability health and released by the former Minister Greg Hunt, and is now at an implementation phase. One of our great PhD scholars and also a staff member here, Julian, has been working to look at representation of people with intellectual disability in custody, and has found that people with intellectual disability are overrepresented by 4-fold, and that they have very high rates of mental ill health and lack post-release supports. And when they do lack those supports, there's an association with reoffending. Some of the complexity that we understand is looking at whether people with intellectual disability are identified pre, during and post-custody, and then their course and whether that label follows the person as they move into different services systems. So you can get a sense of the dynamics of the system. And that's been very helpful in discussions with corrective services. Jules has found more recently that those who are receiving disability services with intellectual disability in prison after release from prison have vastly reduced recidivism. An example here is given in median survival time, which is 911 days for those with disability support versus 286 days for those without. And there's a gradient that those receiving more specialised disability support, even though they have a higher rate of offending prior to release, actually do far better. So you can see a wonderful gradient. He's also examined people with intellectual disability who have serious mental illness in prison, and he's shown that when they receive either community mental health support or disability support, their recidivism is vastly reduced. But if they receive both of those things, it's reduced even further. And you can see the hazard ratio here, 0.45, indicating that vast reduction in recidivism. You can also see that certain factors are associated with higher rates of recidivism, including the presence of mental health conditions, particularly substance use and psychotic disorders. And so if I just give you a snapshot of some of the initial areas that we've been covering, I think I've illustrated some of those areas already in people with intellectual disability, and we'll hear more about that later. Moving on certainly to factors related to frailty and ageing, cancer incidence, cancer screening, immunisation, prescribing, and interactions between services systems. We've examined mortality and health and wellbeing for autistic people. We've begun to look at dementias and people living with motor neuron disease and other neurological diseases, and predictors of residential aged care placement after hospitalisation and health needs. We've just shifted now to looking more at serious mental illness, and we'll give you some examples of that. So I'll hand over now to Prevalence, who will present about practical and methodological issues.
Hi, everyone. I am a senior data analyst here, as Julian mentioned. I oversee all the data, all the ethics issues, and all the planning for the data linkage projects that come from 3D and So here I'm going to share my joy doing ethics with everyone. So the first warning is that the ethics process is lengthy and complicated because when you have multiple sources of data, you need you might need multiple ethics committees. And for each jurisdiction, you also need specific committee. Like for example, if you want to use the data from New South Wales and Victoria, you have to go to the specific ethics committee for both of the states. An example that we do here in our work at 3DN is that we mainly focusing in people who live in New South Wales. So we need to go to the New South Wales Population and Health Services Research Ethics Committee, or New South Wales Pop Health, which is our home institute. And once in Julian slide, when he mentioned that we add AI Commonwealth dataset, and Commonwealth dataset AIHW ethics committees has the only ethics committee that is allowed to approve that dataset, so that we will have to prepare at least 2 applications for the 2 main dataset to get through that. And if you also have your additional dataset, for example, if you, with our work, we use student the data from school, so we need to go through the ethics committee to get that approval. Basically, what I'm saying here is that when you have more committees, mean that you have to do more annual progress reports for each year, and have to answer multiple questions from different angles, because each dataset, each data custodian have different concerns that they do. And another reason that why it's lengthy, because they have limited number of meetings a year. Like New South Wales Pop Health has kind of regular meetings. For the big, if you have the new application, they'll meet 12 times a year. But if it is an amendment, I think for the executive committee, they meet every 2 weeks or something. So it's more frequent than, much better than AIHW, which they meet 5 times a year. And in each step, before you submit ethics to AIHW, you have to talk to AIHW data linkage unit. Once they approve that, then you request a code. Yes, AIHW charges us to apply for ethics now. I can't remember the exact amount, but it's about $1,000 for each of either the new application or an amendment. And another point, you might not think that is only to ethics committee, it shouldn't be too much, but these are the documents that you need to prepare for each of the ethics committee, like the protocol and application for data. Luckily, New South Wales PHDEC has the template that you could write using that template, and you can use it for AIHW, AIHW, accept that. So the privacy form for each one in our data set, we normally, it's not in there. In our data set, because we are looking at the population level, we always request it for the exempt of the consent, because it is more the risk of identification if we ask for consent in our vulnerable population. Another one that actually really important, the 2 things that's quite important and quite detailed here is for data variable list. You could see that like Cheryl will request all the data set that you request. Each variable that you have has to be justified, and it has to be like you have to strongly justify why you need something. And another thing that I learned is that when you decide this your research project, you also need to make sure that you have all the data sets that need to answer your question. If you miss an important data set, the ethics won't let you go away. For another, this is always a delay for us, like the data custodian approval, because you need, for each data set that you requested, you need to have the data custodian. For the data, for the New South Wales data set that Cheryl had, it's quick because they could help us facilitate everything. But for your external data set, for example, with the corrective services data, firstly, you need to go through that committee, and then their committee will give us a conditional approval basing on whether we receive the approval from our home institute. And our home institute won't give us any full approval until we get all the data custodians approval. So it's like, okay, so that's the thing. So for each of the data set, you can check what each data set holds using that website. For New South Wales health data, you can go to Schroeder website and use PHRN or AHW data collection. This is the tip I'll just skip because I already mentioned something. So for the resources required in the data storage, it depending on the data source. If it is state data, you don't need too much, you just need a secure network drive. But if it's Commonwealth data, you will need to go through the secure and approved secure access environment, either Schroeder or the one that AHW developed, which is SRAE, but you need to pay for the access fee. And once the Commonwealth data is involved, you would need to, everything has to go through AIHW because it's the sole curator. So basically it's in and out, has to be approved, and the curation process normally takes 2 weeks. For statistical packages, it depends on what people are comfortable with. But the note here is that if you have a really big data set, let's say about over 1 million records, might not be able to do the work for you because it struggle with the data that we tried before. And you also need biostatisticians or data analysts because you need someone with experience to do the data quality check, data cleaning, help with the study design, and prepare the analytical file. So when you come to designing the methodological, like designing the study, you need to consider some of the biases, which is like confounding measurement bias, selection bias, immortal time bias, and also consider the reproducibility or sometimes lack of reproducibility. What we do at 3DN to improve our reproducibility is we trying to use concept sheet, and we have a detailed analysis plan that we think through everything, and sometimes with the causal diagram to make sure that it's okay. And in the analysis plan, we have multiple study designs that people could choose from. And when it comes to, once everything is agreed and it comes to the style guide for coding, when it comes to the programming, we also use the style guide for coding so people can view the code and understand what the code is about. So just a reminder that when you do the link data, the data is not recorded for research purposes. You have to ask the right question. You have to understand the data, understand that whether we can identify the outcome from the data we have or the exposure. And if sometimes we get the unexpected result, you have to prepare for have alternative explanation from what you expected. Another thing is for the reproducibility, you have to be transparent. So that's why in the analysis plan, you should outline all the steps taken and then use that in the paper that, okay, I use this code, etc., for to identify the outcome and exposure. And this is it for me. So I will hand over to my next presenter, Dr. Rachel Swage. She will be presenting the results from her work in people with serious mental illness.
Thank you so much, Priyapon. So as she mentioned, I'll be giving some examples of how we've used our linked data assets to look at various health outcomes among people with serious mental illness. And Julian, if you could go to the next slide, please. So in our projects, you know, Priyapon mentioned the importance of being able to define both the population group and also outcomes. So in our projects, we've defined serious mental illness as a mental health condition that's required inpatient care. And within our hospital data sets, we're able to isolate various mental health diagnoses. So, for example, mood and affective disorders, people with psychotic disorders, people with anxiety disorders, personality disorders, and all of these are based on ICD-10 criteria. For outcomes to date so far, we've mainly focused on presentations to emergency departments, hospitalisations, contacts with ambulatory mental health services and deaths. I won't be talking about deaths today, but I will be talking about the top 3. But there's also many other possibilities. You could see from the data sets that Julian shared, there's potential to look at prescribing patterns, contacts with other out-of-hospital services, contacts within the criminal justice system, as well as access to preventative health care. Next slide, please. So here's one example of a study that we did here. So we used our linkage to identify over 165,000 people with serious mental illness, of whom 60,000 had a psychotic illness. And so here we were interested in comparing health service use of people with psychotic illness to people with all other types of serious mental illness, focusing on ED presentations, hospitalisation, and ambulatory mental health service use. So obviously, this type of cohort size is extremely valuable, as is the potential to instantly have access to up to 12.5 years of follow-up data following an initial hospitalisation for serious mental illness. Next slide, please. So using this data, we were able to show higher rates of emergency department, hospital and ambulatory mental health service use among people with psychotic illness compared to people with other types of serious mental illness. And we also highlighted the impact of other factors on health service use. So, for example, people with indicators of more complex support needs. So, for example, people with intellectual disability or greater physical morbidity had higher rates of health service use. One important finding of this study was that even though people with psychotic illness had higher rates of hospitalisation, which when we looked at the reasons for hospitalisation, we saw that that was largely driven by mental health, hospitalisations for mental health conditions. We found that actually hospitalisation for physical health conditions, the rates were higher for people with other types of serious mental illness. So using this, we were able to highlight the point that, or the importance rather, of expanding programs that focus on improving the physical health of people with serious mental illness, which often actually focus or target people with psychotic illness. The importance of expanding that to all people with serious mental illness, not just people with psychosis. Next slide, please. So moving on to example 2, we ran a study in which we focused on people admitted to hospital for self-harm and looking at the impact of problematic substance use on representation to an emergency department and hospital for repeated self-harm within 12 months. So again, here we were able to form a large cohort of over 23,000 people who were admitted to hospital for self-harm. And of those, about 25% had a co-occurring diagnosis of problematic alcohol or drug use. Next slide, please. So in this study, we were able to show factors associated with repeated presentation to an emergency department for self-harm, as well as factors that were associated with the severity of that repeated self-harm event. So we found that people who were younger, women, as well as people with combined problematic drug and alcohol use were more likely to return to an emergency department for repeat self-harm within 12 months. But once presenting to the ED for repeated self-harm, it was actually people who were older, men and people with problematic alcohol use specifically, who were more likely to be assigned a more urgent triage category or were more likely to be admitted to hospital. So here we had findings that highlighted unique risk factors for representation and severity of self-harm, as well as highlighting the importance of addressing problematic substance use to prevent repeated self-harm. So I'll be handing over to Simone now, who will take you for the next rapid tour, using an example for one of our studies focusing on people living with dementia.
Thank you, Rachel. So yeah, I will present a current project using our linked data on self-harm and dementia funded by Dementia Australia. Next slide, please. So just a brief background, dementia and self-harm are substantial public health burdens in older people. The risk of suicide increases in old age, in particular in men. And dementia has been identified as a risk factor for self-harm behavior, in particular in older males. Suicide and self-harm interventions targeting people with dementia and older people in general are sparse, and more research is needed to understand factors that are associated with self-harm and dementia, or self-harm in dementia. And understanding the precursors of self-harm in people with dementia can help to inform the development of interventions or preventative programs and appropriate service provision before self-harm occurs. Next slide, please. So we established a population-based retrospective cohort of people with dementia with and without self-harm who received health services in New South Wales from 2001 to 2016. And we used our linked data from hospital admissions, emergency department presentations, ambulatory mental health consultations, and cause of death records to build a large cohort of New South Wales residents aged 40 and above with a hospital record of dementia and self-harm. And then we divided this cohort into those with dementia without self-harm and those with dementia and a subsequent record of self-harm. So we have 154,159 people with dementia who don't have a record of self-harm, and we have 652 people with dementia plus a subsequent record of self-harm. And those living with dementia who have self-harm have a younger median age than those living with dementia without self-harm. An important part of this project is the inclusion of a Dementia Advisory group consisting of people living with dementia and carers of people with dementia. And this group has been incredibly important to shape this project. They helped us to identify issues of importance to look at in our data, and they helped us to make sense of some of the preliminary findings and their implications. They give input in what we can and should do in terms of developing resources and also for disseminating the findings and what are the best ways and channels. Next slide, please. Okay, let's look at a very brief snapshot of some of the results. So the rates of health service use was highest in people with both dementia and self-harm, here in the green bars, compared to people with only dementia or with only self-harm. And this was in particular for hospital admissions and emergency department presentations. More than half of the self-harm hospitalizations occurred in the 12 months following an initial hospitalization for dementia. Next slide, please. More people with dementia plus subsequent self-harm had physical comorbidities, and a higher rate had involuntary mental health admissions. About 38% had 2 or more emergency department presentations in the year before self-harm, compared to about 30% of people with only dementia. And a much higher proportion of people with dementia and self-harm used ambulatory mental health services compared to people with only dementia. Next slide, please. When we looked at the health profiles and service use, we saw that a higher mental health ambulatory service use and having more physical comorbidities were associated with an increased risk of self-harm. Also depression, drug and alcohol use, psychotic disorders, anxiety, behavioral problems, and personality disorders were associated with an increased risk of self-harm in dementia. And men were around 5 times more likely to be hospitalized than women. Next slide, please. So in summary, men with dementia were at higher risk for self-harm than women with dementia. More than half of the hospitalizations for self-harm occurred in the first year following a hospital record for dementia. And we specifically looked at this first year after a diagnosis of dementia, as this was suggested by our advisory group, that this period of time in particular is crucial. People living with dementia who self-harm had an elevated risk had an elevated rate of service use, including hospital admissions, emergency department presentations, and mental health ambulatory visits. And complex mental and physical health profiles increase the risk of self-harm and dementia. And our project builds an evidence base to guide health policy and services for people with dementia and highlight the importance of support and preventative measures to reduce self-harm. Next slide, please. So to conclude, there are multiple risk factors associated with self-harm after a hospitalization for dementia, particularly within the first year. Men around the age of 70 with complex health profiles, especially the psychiatric profile, are particularly vulnerable and may profit from extra support. Self-harm in people with dementia likely represent unmet needs. For people recently diagnosed with dementia, the first 6 to 12 months after diagnosis, when cognitive functioning may still be relatively high, are a critical window to provide supports for people living with dementia. There are also a number of limitations to this project that I would briefly like to mention. So first of all, we don't have primary care data in our linkage yet. So we miss a large proportion of people who only see their GPs. And the diagnoses in our study were based on hospital admission data. So there is a lack of more detailed clinical information that would be useful to dig deeper. Next slide, please. I would like to thank Dr. Adrian Walker, who coordinates this project and who ran all the analysis and drafted all papers. And thank you. And now I'll hand over to Janelle.
Thank you, Simone, and everybody for the introduction so far. The work I'm going to talk to you today is about the role of data linkage within health service evaluations. I'm not going to spend today really talking about the results from the evaluation, but more talk broadly about the approaches that we've applied, the lessons we've learned, and some of the challenges we've faced. And obviously, I'd like to acknowledge that this work is part of a larger team. Next slide, please. So today I'd like to talk about the lessons we've learned from 2 health service evaluations. This includes the Intellectual Disability and Mental Health Residual Functions Program and the Intellectual Disability Mental Health Hubs. And both of these evaluations really aim to look at what sort of impact did these services have at an individual level for their person's support network, and also what sort of role did they have in equipping the service sector. And our evaluation approach was very much a mixed methods approach, so data linkage being only one element of it, applying a co-design approach where we really value the voice of people with lived experience. And so it's through the data linkage that we were really able to highlight the impact that these programs have or haven't had at an individual level. Next slide, please. So what data linkage allows us to do is it really nicely captures all of those people who were enrolled in a service and participated, and it gives us a nice profile about who these people are. Within our current linkages, we're able to look at what sort of public health service utilisation these people had both prior to starting within a service and then what happened to them after engaging. We're able to also look at outcomes, so particularly mental health outcomes, and we can also extrapolate out from this data linkage sources what sort of economic impact a service has had, which is exceptionally important when people are trying to make decisions about whether further funding should be provided to facilitate these programs. Next slide, please. So here I've just given a bit more detail, and I think my colleagues have really nicely highlighted this, but just for those unfamiliar with data sets, is the type of detail that we can provide. And so while it's really lovely to see those high level information about rates and treatment days, the value we also found is in these kind of more detailed explanations about service utilisation. So for example, we've been able to track different types of provider types, activities and categories of service. And that's really given us great insights into what sort of impact these programs have had on that cold face of service delivery. Next slide, please. So I just also wanted to raise, obviously the team spoke about Cheryl linkage where we're able to, that's one avenue, but we've also used a data extraction through Inform. And I guess both of those have pros and cons. So the data extraction method allows us to do it much more rapidly, but it only allows us to look at service users. Whereas when we go through Cheryl linkage, as my colleagues have alluded to, we can not only identify service users, but their matched control groups. I'd also really like to highlight here the importance for any program evaluation is being able to identify the people. And I think it's really wonderful when these services were designed that this was thought about, and each individual user was given a service code, which allowed us as the evaluation team to find these people. As we know, this is a huge issue with identifying people within administrative health data sets. Next slide, please. So what are some of the lessons that we found? So as I alluded to, having a program code where we can find people is exceptionally helpful. The details on the type of service provision helps us to understand, so the who's, the what's, and the types. And I think that's exceptionally important when we think about any future changes that we want to make to health service provision. Obviously, data linkage only provides us with a snapshot of information and the real value of triangulating this with qualitative data. So what does all of this mean? And as I mentioned, our data linkage only lets us look at that individual service user perspective, not really the impact that it's had on the broader network of people involved or engaged in a service. We also really value the role of the lived experience researchers in the design and interpretation of our findings. As Priyaporn alluded to, sometimes we find unexpected things, and it's really helpful in those circumstances to be able to discuss and explore why those findings might have occurred. Next slide, please. So some challenges that we face, which may be applicable to other groups for those of you who work in different areas. So for example, we're unable to reliably stratify by severity of intellectual disability. And this has implications because we know that it impacts on mental health profiles and mental health service access. So particularly when you're thinking about trying to understand the impact of a program, understanding who the program users are is exceptionally helpful. In terms of understanding mental health outcomes, so what sort of impact did the program have on the outcomes for people, was particularly challenging because the data was not always captured completely. There's also the costs associated with linkage and a lag in the availability of data. So there can be, differing timeframes in lag in data between when it's put in by clinicians to when we're able to access it for linkage. We also struggle with, and obviously many projects have finite time. So, what sort of time frame allows you to accurately reflect the impact that a program might have had when you're looking at changes in service utilisation. Also, interpreting our findings can be challenging. So, for example, for many people with intellectual disability, we sometimes see when you engage in a meaningful service, we may see a spike in service utilisation, but that doesn't necessarily mean a bad thing. That might be just that you're getting the care that you otherwise have been missing. So I guess it's taking that nuanced approach to trying to interpret your findings. Next slide. Thank you, and I will hand back over to Julian to wrap this whirlwind spin of 3DN's data linkage work.
Thanks so much, Janelle. I just wanted to highlight a couple of points, just echoing what Janelle said. Often all we're doing with data, and it's the power of data is enormous, is simply demonstrating what people with lived experience have told us all along. So that power of working with people with lived experience in interpretation is really critical, and taking the next steps and knowing what to do about the findings. We've progressively become much more used to working with data, and some of the innovation I think that occurs as you do is that you become very familiar with the data sets, how they can be used, how people with particular conditions can be identified reliably, and how to use that. We've begun using the data in interesting ways. One of the ways is creating a new portal for local health districts, which showcases the health and service use of people with intellectual disability living within that local health district. And that's accessible to planners and policymakers within each local health district. We collaborated with colleagues from UTS to create a local government mapping, which allowed local government areas to understand who is living with intellectual disability within their zone and to address some of those local needs. Some of the other innovations come from comparative analysis. For example, because of the way we linked across multiple different data sets, we had different sources of information about cause of death, some coming from very rich data from the New South Wales Ombudsman that used to conduct an inquiry into each death in disability care. And we're able to compare that to cause of death coding in traditional data systems, showing a real discrepancy. Once you were able to have an in-depth investigation into cause of death, you understood the death in greater detail and often came to a different conclusion about the cause of death. And of course, like many in this field, we've begun to apply machine learning approaches to data analysis. This is a data portal that I mentioned earlier, and this is just a screenshot showing some of the statistics you're able to demonstrate and benchmark local health districts against like local health districts, and benchmark against the whole of New South Wales population and the whole of New South Wales population living with intellectual disability. And this is just emergency department presentations. You can see that for this particular local health district in black, their emergency department use is way above the general population, but similar to other local health districts in New South Wales. The data portal also gave a clear understanding of the demographics and health profile, health service use and costs associated with care for people with intellectual disability living within that local health district. And I don't really have time to go into further detail. This is the heat map of the prevalence of intellectual disability in New South Wales by local government area. And of course, there was far more detail than that, but that's just all I can show you at the moment. Some of you have been collaborating with us on a new big data project where we're trying to bring together all people in New South Wales with neurological, developmental, or mental health diagnoses and matched controls, and link them not only to New South Wales data sets, but to Commonwealth data sets. And you can see just by the sheer volume of data sets displayed here on the screen, both in terms of cohort formation and outcomes and exposures, that this project is absolutely massive, and also involves, as I said, a control group. The linkage will hopefully, if it's approved through ethics, and that's shortly to go in, will be managed by both the Centre for Health Record Linkage, Cheryl, and the AIHW. I'd also just like to highlight the future for particularly disability data. We've been part of a team working on a council to advise government on the formation of a new asset, which is this third generation asset that I referred to previously, with an enduring linkage across multiple health and human service agencies at a state and Commonwealth level. And this is currently still being worked out by government, but certainly is in the next phases now, following a report that the council delivered late last year. And I'm hoping that that will allow both people with lived experience of disability to understand and have insights into their health and wellbeing, as well as researchers and agencies to have a better understanding. Interestingly, COVID has been a key catalyst for data linkage. At the beginning of the COVID pandemic, working with the Commonwealth Department of Health, it was strikingly obvious that we were unable to identify people with disability by disability type and understand how they're impacted by COVID, what the vaccination rates were and what the outcomes were. And so progressively, we've been pushing this idea of linkage, which has been forthcoming, which is great in most jurisdictions, and we've been able to get better insights, but it's been a real push along for the National Disability Data Asset. So just in conclusion, we found that linked data is rich in its insights, but it's one component of a broader inclusive mixed methods program, and I think that's been highlighted throughout. It's a powerful tool for populations experiencing health inequality, and really needs to be paired with a strong inclusive research approach and a robust knowledge translation strategy, including advocacy, to maximise the impacts. Whilst there are major barriers to planning and execution of multi-agency linkages, we're optimistic this will improve with time. So thank you for your attention. We welcome questions.
Thank you, Julian and the team. I'd like to start with the first question. This question is for Rachel. Does the hospitalization data for mental health conditions include private hospital? I think it will be a different population of people who is with mood disorder who gets admitted to the public psych ward versus the private facility, both in terms of socioeconomic status, top covered private health insurance, and severity of disease. What is your comment?
Yeah, this is a really good question. So for that particular study, so I guess the short answer is the hospitalisation data does include both private and public hospitals. For this particular project, for that very reason, we limited our analysis to the public hospitals only. So I guess this was a situation where, having, we had clinicians on our team, we had domain experts, analyst experts, and being able to get that input to know actually what would make most sense for our particular research question was really important. So that particular study, we excluded private hospitals.
Thank you, Rachel. And Kimberly had another questions. I think it's maybe for the whole group. But given the challenges and delay associated with the record linkage research, ethics, data custodian approval, etc. So what appetite do you think there is for expansion of the master linkage key idea, such as the CHEREL or similar, creating regularly updated linkage data set with existing approval in place, potentially even made publicly available for analysis as occurs internationally? What are your thoughts?
I think this is where we see something of the value of the proposed national disability data asset, that you could apply that to other sort of major initiatives nationally. I don't think it'll be long before we see that sort of generation with enduring linkages. But the difficulty, of course, you have there is historically jurisdictions have been very cautious about those enduring linkages shared across jurisdictional boundaries, and you need a lot of robust quality and governance aspects addressed before custodians are willing to hand over their data and allow it to be part of that sort of system. That's what we're dealing with now.
Thank you, Julian. So I have another question for Simone. My question is talking about the self-harm in individuals with dementia. So do you think that the increased risk of self-harm in individuals with dementia is explained by higher rates of any specific types of mental illnesses than non-dementic individual? And is there any social demographic factor that could modify the association between dementia and self-harm? What are your thoughts?
You can still hear me because I think my video stopped working. But can you still hear me?
Yeah, sure.
Good. Okay.
Yeah, we can hear you.
So yeah, the mental health factors or mental health disorders that we found associated mostly were depression, anxiety, and psychotic disorders, and that was similar for people with and without dementia. I don't have the exact numbers now in my mind, but these were the main mental health issues. And in terms of socio-demographic factors, I mean, yeah, men, like the risk was highest for men, so being male is a risk factor. And we found that being married, people who were being married had a higher rate of hospitalizations for self-harm than those being divorced, widowed, or separated, which was surprising at a first glance. But it may be that people who are married, the partners bring them more often to a hospital or prompt them to go to a hospital than those who are separated.
Thank you, Simone. Another question from Rebecca is for Julian. A lot of service data sets like MHOAT have a fair bit of missing data. What can we do to encourage busy clinicians to complete this outcome variable that might have an immediate impact on their clinical practice, but it's important for effecting change in service delivery? Any wisdom?
I think we need to be absolutely clear that data collection has a potential enormous benefit to the people with mental illness we support. So we might think this is just not a clinician's job. But in fact, because it has such huge flow-on effects to what we can do in understanding the needs and outcomes, it's an absolutely critical part and should be considered part of clinical care. But of course, the reality of working in a busy services system is we never have time to do the things we need to do. So, we certainly need more people working in our field and a better level of funding for it.
Thank you, Julian. I have a final question also for myself. So I noticed that if I see the data correctly, the age trend of mortality in elder individuals with intellectual disability seems to suggest that the healthcare needs become less than other elders without intellectual disability. I wonder if this is because of a combination of survival bias and age-dependent barrier to healthcare specific to people with intellectual disability.
Yes, it's a survivor bias, I think, predominantly in that people die early, on average 27 years earlier than the general population, and have frailty that has its onset at least 25 years earlier. So we're seeing only healthy survivors toward the end. The other issue that occurs is that people tend to move from disability data sets where we can identify them to aged care data sets. And so they may lose the identifier as they progress. We think that's only an issue for those over the age of 65, of course. So it doesn't explain why things drop off much earlier than that. I think it's survival bias.
Thank you, Julian. Let me see if there are other questions. Yeah, Ian has a comment about the administrative support for tests that don't require clinical training. I think with regard to the comment on the encouraging the clinician to provide more data. Okay. I guess we don't have any other questions at this point of time. Thank you, Julian and the research team. It's really valuable and insightful presentation, and I believe that the audience have learned a lot about that and a lot to digest when we get back.
Thank you. It's
So
really been a pleasure. Great privilege to be chatting today. Thank you.
Thank you all. So we're gonna end the presentation right now, and please join us next month for the talk of Associate Professor Jane Goff. And thank you again, everyone, for attending and participating. We welcome any feedback regarding today's session, and you can send your comment to the email address on the screen, or I think, but you can send it to Ria or the Psych administrator. We'll be happy to address the comments and get back to you later. So until next month, take care, everyone. Thank you. Oh, Karen has a comment. Karen, you have a comment?